Hi everyone, welcome to another Monty Hart lecture series. Today we have Dr. Marcio Bittencourt, who will be speaking about coronary CTA as the initial test for the assessment of suspected chronic coronary artery disease. It's a real pleasure to have Dr. Bittencourt here with us today. He graduated in medicine at the Federal University of Paraná in Brazil, completed his internal medicine and cardiology training at the University of Sao Paulo in Brazil as well, then trained in cardiac CT at the Erlanger-Nuremberg University in Germany with Dr. Stephen Ackerbach. Then he completed a PhD in cardiology at the University of Sao Paulo and an MPH at Harvard School of Public Health. He also did a postdoctoral fellowship at the Brigham and Women's Hospital in Boston. He was the director of cardiovascular imaging at DASA Sao Paulo in Brazil and the director of cardiac CT at the University Hospital from the University of Sao Paulo in Brazil. He currently works as an associate professor of medicine at the University of Pittsburgh, and is also the director of cardiac CT at the University of Pittsburgh Medical Center. Dr. Bittencourt is currently an associate editor of Circulation Cardiovascular Imaging and also Arquivos Brasileiros de Cardiologia and the Brazilian Journal of Medical and Biological Research, and he's also a past member of the board of directors from SCCT. He has over 250 peer-reviewed publications, and personally, I love his lectures. I've seen him at AHA, SCCT, and he's an outstanding speaker. So thank you so much for being here with us.
Thank you. Thanks, everyone. It's great to have the opportunity to talk about this topic that I really have interest on. This is sort of my main interest in the CT and to some extent the clinical and the epidemiological space. As you'll see, the talk is a lot less imaging than people would expect in an imaging round, but I think contextualizing how we use imaging is one of the most important things we do when you take pictures of patients. So the title is very broad, but very specific, and I chose some words wisely, and I'm going to talk first about the initial test. I'll be a bit more than the initial test at some point later in the talk, as you will notice. And this is assessment of suspected CAD, as most of the patients come in before the initial diagnosis. So I'm not going to talk that much about post-revascularizations and people. We know there's coronary artery disease from before, though I might touch a little bit on that. These are my disclosures. Some of them are not even recent. This is not necessarily my super updated disclosures. Elucid is a company that does software for plaque assessment, as is clearly. None of them, I'm not even going to talk about plaque assessment with the advanced softwares, to be honest, but none of this has any major relationship with what I'm going to talk about. Some of the drug industries here, I will talk about things that are guideline recommended, but nothing off label or anything like that. So what I plan to discuss, and again, as I said, some stuff I want to be very broad. One of the broad things I want to discuss is how do we assess if a diagnostic imaging test is good? How do I assess the efficacy of a test in a structured way, in a comprehensive way? And then I want to come from that framework and show that how much CT has done to prove its efficacy, to kind of construct on a framework of how coronary CT can be used to assess as the centerpiece of the clinical assessment of stable chest pain, of possible coronary artery. And also, once you find out that it's coronary disease, how can we consider this complex scenario to make the adequate diagnosis, prognosis, and management? So I'm going to cover how do we know what is CAD, how do we consider the risk, and how do we manage, and mostly based on CT, as you'll see throughout the talk. And then a little bit of this has to do with decision science and how we make choices, because I think it's very, very important for the way we use the tests. I'll start where we are, and we are with current guidelines saying that imaging tests like coronary CTA are recommended to diagnose CAD in symptomatic patients as a class 1 indication by the European guidelines for the evaluation of chest pain. And they put this sort of a figure that says anything intermediate, which is not too low that you don't need any testing, not too high that you want to be aggressive. You can do any non-invasive test. Maybe they suggest CTA towards the mid to lower end of the spectrum, maybe ischemia to the other side, but both tests, depending on local expertise, sit on the broad intermediate range, which would be from 15 to 85% of pretest probability by their guidelines. most recent European US guidelines are not that different. They basically split the risk in low risk, where no testing is needed, and everybody else where you can either do CT or stress testing. So both two of the largest guidelines we have for chronic coronary artery disease basically say, yeah, CT can be the first test for pretty much everybody. There is the alternative or the classic old or traditional approach with stress testing, but equally valuable. And this might sound for many people already kind of, yeah, that's obvious. That's the standard where we are since 2019, depending on the guidelines. So it's been more than 5 years. What's new in there? But I'll take a step back and not to say what's new. I'll go back and say how new those things are from what we usually think in medicine. And it's interesting if you go back. This is 2006, so it's a little less than 20 years. And 20 years ago, Stefan Achenbach was taken by many as sort of a godfather of cardiac CT and coronary CT on sort of a state-of-the-art paper. What we would say is, oh, we have the desire to do reliable imaging. Maybe we can see imaging in a stable quality. And everything we talk about is maybe we can take nice pictures in some patients with the newest scanners, and the images are okay. And we don't have any clue other than that. And that's what was published in 2006. In 2007, even on the CT journals, this is JCCT, where we usually are more prone to say CT is great and we have all the data to support it. 2007, what we would say is prior evidence going beyond pure imaging, like clinical outcomes, just limited. We don't know. And then if we go even 2010 on the expert document about CT, we would say we don't have data about prognosis with adequate statistical power to allow adjustment for multivariable analysis and other things. So basically, it's like 14 years ago, we were saying we don't have a clue how this performs from a clinical perspective. At best, we know we can take nice pictures. So in 14 years, we've been through a lot, and that's what I plan to guide you guys through on the first part of the talk. And by that, I will use, as I said, a structured framework to assess the efficacy of any testing. This has essentially been designed as a way to assess imaging tests, but it will work the same way for any lab test or any other additional ancillary tests we use in medicine. It's known on the decision science as the Freiberg and Thornbury classification. And basically, I'm going to go through multiple levels on what the test has to prove to show its efficacy. And it starts on the technical, like, can I do a test, and goes all the way through making sure this test is valuable to each individual patient. The first one is easy, and I'm not going to spend a lot of time on that, but that's what we were doing about 2005, 2006, which just showing technically this works. And we all know CT in general works, and we know that arterial contrast works well. So making pictures of vessels is something that has 50 years plus on CT. So the new thing that took us up until 2004, 2005 with cardiac CTs, just that the heart moves and the vessels are small. So we need decent motion adjustment or good temporal resolution and good spatial resolution. I said, I'm not going to spend a lot of time on this, but all of you have seen those CAD films, and you can just appreciate, if you look at it, how much does in this case, the circ moves, and to some extent, some parts of the LAD. So if you make a picture while they're moving, you're screwed. And if you look on the other graph here, there's a good pause on diastole around 70-80% of the cardiac cycle, and a shorter pause on around the 30-40%. And this one is not even the same necessarily for all coronaries, the systolic one. So it's not that easy to get a standstill picture. You need to make all the image in the systole or all the image in this small duration of the diastole. And that's what took us very long to do the cardiac CT, to pass the technical efficacy information. Nowadays, this is pretty obvious. The images here are just like one with motion on below, one without motion on the top, and the arrow just pointing to the RCA. And I think this is not even current anymore. I didn't update the slide, but current from a couple years ago, all the vendors had nice, way beyond what we need for most cases. With some beta blockers, almost every patient can get adequate heart rates that we can take pictures. But this was the main step that got us on hold versus other vascular territories up until 2005, 2006. So the more we've been improving the temporal resolution of the scanners, the more we can go on higher and higher heart rates, less beta blockers, and better image quality. As I said, this is the easy step, so I won't spend too much time on that. Step number 2, if you want to say the test works, it's just you have to prove it is able to diagnose what you want to diagnose. And the general classical interpretation of CAD back when we were testing CT, I'll extend that later in the talk, but traditionally we wanted to know who has obstructive disease, usually defined by CAT, sometimes more recently defined by some invasive measurement of pressure gradients, being that FFR, IFR, or something else. But initial data, again, as I said, 2008, when we start to have more robust data on this, and this is a very interesting, probably the largest one back in time. It's a New England paper with 64 detector scanners. And this is basically an AUC curve to detect a 50% stenosis on QCA. So essentially, how good is CT when it says above 50 to match the invasive angiography above 60 diagnostic criteria for defining obstructive disease? And it was pretty good. Area under the curve on this study, 0.93. Sensitivity a little lower than other studies that published back then. Specificity probably comparable to the other ones, but overall, a very good profile. But one thing that I would point at this stage is what we've learned also since 2008 is also invasive angiography is not that perfect. So not sure all the wrongs from CT are necessarily CT's wrong, versus also invasive angiography might be wrong, because the definition, what's really disease that we're looking for, has been changing over time, and there's no real gold standard to define what we're looking for. We might be looking for plaque, we might be looking for ischemia, ischemia correlating with symptoms, as symptoms, flow gradients on the lesions, etc. So it's a little gray, but what I think is very interesting in this study that people don't pay as much attention to, but in the Core 64, they did another ROC curve comparing CT to cath, and then the outcome is this is going to be revascularized. So what I see and kind of say, severe that can be revascularized, or they will be revascularized, and then cath says same thing, then they're completely overlapping. So to predict revascularization, so is this vessel going to end up with a stent? CT is as good as or as bad as QCA. So if you say, oh, CT is not good enough, then probably at least in 2008, in a structured blinded study, QCA was also not that great. Very, very overlapping AUCs like 0.84, 0.82. If anything, the area under the curve of the CT is minimally higher, but this is pretty much the same. So at this stage, we can clearly say CT is as good as invasive angiography to predict at least the intervention that's going to follow. So pretty good performance to detect disease. More recent, more current data, this is a meta-analysis of individual patient data. Excluding disease or detecting the non-obstructive, the disease versus obstructive disease, AUC 0.95. So really, really good performance to detect obstructive disease versus invasive angiography, as long as you exclude the non-diagnostic segment. So as long as I only look at the ones I can see. If you want to say all comers and count the ones we're not sure, then it's a little lower, but again, a little bit better than or comparable to core and to most of the literature. This study also added something that I think is interesting. Some people don't want to do CTs on older individuals because there's too much calcium. And you see here, at least until the age of 75, performance is exactly the same. It's a little lower on the greater than 75, but not by a lot. So probably shouldn't use an age cutoff not to use CT because it works really, really well. Then we have another study that uses the outcome as being FFR, invasive FFR. So versus the invasive measurement of flow decay on that lesion, CT has very good sensitivity, lower specificity, of course, because some of the anatomical lesions of 50, 60, 70% may not have flow limitation. So kind of understand if you come up from a purely anatomical assessment, what you're seeing may or may not correlate with flow, but you see most of the disease, and you might overestimate, let's put it that way, on the specificity, the flow impact that you're going to see on the invasive angiography. But with diagnostic accuracy comparable to other methods, at least to the traditional SPECT, but very, very good sensitivity that's comparable to what PET gets. So overall, very good performance, even if you compare with a flow assessment instead of an anatomical testing. That would be the head-to-head comparison with what CT does. So that's pretty much, I think, for us to say that I think the accuracy in terms of diagnostic perspective is pretty stable. So we know if this is obstructive CAD or not to a certain reasonable reassurance that we can just move to the next level. And level 3 is where we start to get things more interesting. The traditional Fryback and Thornbury classification calls level 3 diagnostic thinking efficacy. So that's when it informs your diagnostic ability. That's when it tells you as a clinician use the level 2 information in a meaningful way. Meaning, before the test, I didn't know what it was. After the test, I know what it is, or I'm more certain of what it is. This test is helping me on the diagnosis, and ideally versus other methods that we currently use. But I'll add to that a little bit on in chronic diseases and in coronary artery disease, the chronic version, we don't only want to know does this help knowing what the patient has, but also what's going to happen. So I'm going to add the prognostic thinking or the prognostic information also on this level 3. And the data for the classic diagnostic thinking is actually very clear. I pulled the data and create a graph. This graph is not exactly how it is in the paper, but this is Scott Hart's data. The classic original Scott Hart paper from 2015. It's very interesting because they asked the clinicians on the x-axis, how likely do you think that this patient has obstructive CAD as the cause of the presentation? And then they ask afterwards, which is in the color-coded part, 6 weeks later, after you got the CT results or the standard care when they got the treadmill test result. Say, how likely do you think it is now that you got the test result? And what you can see on the right side is the stress test didn't change anything for anybody. All the no's stay green, stay no. All the red stays red, so all the yes stay yes. There's a minimal change on both directions of the probable, and there's a minimal change from the unlikely, or maybe because the stress test came positive, they're now probable. But minimal change within the intermediate or the unclear diagnosis, and not much change. So didn't add anything to what the clinicians were thinking. You look on the other side, this is quite impressive. You get on the people you said, this is not angina. And then you turn your impression, 25% of the patients flat out to say, no, this is angina now. I really think it is. And then another good chunk, you say, I'm not sure. And then the unlikely, most of them stay unlikely, but there's still changes on both directions. And on the probable, a bit more. But even on the yes, we have some people that move to flat out no, which probably is a normal coronary CT. But the changes here basically show clinicians first believe the CT, but second, based on the anatomical information, are changing a lot their clinical knowledge. So CT makes a difference on how you feel from the symptom presentation before and after the test results. I have to be honest here, into the CT arm was not just CT. So 6 weeks later, patients would come in with a treadmill stress test and a CT. So it's really more reassuring both directions when you have both anatomical and some form of stress testing. But still, this is how much CT added compared to the one that had the treadmill only on the other side. So I think this is enough for to say, well, from a diagnostic perspective, it does add, and people do see the disease differently once they get the CT results. So let's go to prognosis. This is the first classical meta-analysis on prognosis, the first smaller papers. Pretty basic, no disease, non-obstructive, obstructive disease. We can kind of ignore the revascularization big bars here because it might be driven by the test results, but we do see graded increase in MI, graded increase in death, and MACE, of course, has something driven by revascularizations, but overall, everything trending the expected direction that the plaques we see, obstructive or not, indicate some increase in risk. The more obstructive the plaques are, the worse the event rate or the higher the risk of the patient. This is next step of this analysis. This is an analysis I did when I was in Boston. And here it's all adjusted by clinical variables. So this is all hazard ratios adjusted for the baseline information. And what we did here was we got the non-obstructive and just gave some estimation of the extent of plaque, how many segments with plaque as based on CT. And same thing for obstructive. Number of segments with plaque, not with obstruction. So this group has multiple segments with plaque and at least one obstructive. Here, not so many segments with plaque, but obstructive. And what we see here is kind of the obvious pattern, but some interesting stuff. Yeah, obstructive disease is worse than non-obstructive, but more plaque on each group is worse than less plaque, which is kind of obvious nowadays. And more plaque, even if non-obstructive, on top of an obstructive lesion, also worse. Given some of the known information now that the more plaque you have, the worse it is, obstructive or not. So it's really the plaque burden overall that brings the risk in. And then even more than that, CT went on characteristics of plaque as prognostic tools. This is data from PROMISE, which we're going to talk more about later, but 2018 data from JAMA, where they looked at the higher risk features. So aside from the stenosis that define the obstructive plaque here, so the difference between the SS positive and negative, they said these 4 features, the 3 classic ones, positive remodeling, low attenuation, spotty calcification, plus napkin ring. And they basically split the data in, do you have the high risk features or not? And here you have the non-obstructive, having the features is worse prognosis, still way lower than the obstructive levels, but same pattern obstructive. So regardless of having plaque that is obstructive or not, the additional information brought in by the plaque characteristics that indicate high-risk plaque have prognostic impact. So it is, do we have plaque, how much plaque, how obstructive the plaque is, and how the plaque looks, that collectively give you a CT information of prognosis. So I think there's enough data to say presence, extent, severity of the obstruction, and plaque characteristics all support the idea that CT has very good diagnostic / prognostic information for us to diagnose obstructive coronary artery disease on the stable chronic patients, as that's the case of all these patients. But then the next question, for a test to be useful, it has to change the management. I don't take nice pictures just to tell the patients what they have. If I can't change anything what they have, it's a questionable value of the test. So can we change? Should we change? And does the changes that we make for patients in terms of medication have impact that is worth making the change based on CT? This is our early data also from when I was in Boston. We started to show that even non-obstructive plaque end up getting more aspirin, and definitely the more obstructive plaque, even more than that. So clinicians were reacting to the CT findings in terms of antiplatelet therapy. Similarly for statins, so you can see here not just overall higher prevalence of people on statins, but also increases in dosage. So people that were already on statins, the dose was doubled, tripled, or whatever, but there was an increase in the use of statin after the detection of non-obstructive and obstructive disease. But again, this is what physicians did, and the data to support it, it helps, was not available. So in that analysis, it's a retrospective analysis, but what we did is we got only the non-obstructive disease, because obstructive might have gone to CAT and got interventions based on that, so it wouldn't help. So this is only the non-obstructive group, so this middle part. And we did a propensity matching and look at the extent of plaque. If you have very little plaque, your prognosis probably is too good for us to see a difference in 3 years. Not saying it doesn't make a difference, but we don't have power to detect. But once you have more plaque, which is to us with SIS greater than 4, you can see the statins improve prognosis. There's other studies that have kind of showed the same afterwards, but it's the idea that the amount of plaque that we see can guide, can inform us on managing the patients for at least some of the clinical information, and that can have impact in prognosis. Again, on the medication, there's very interesting data on the side data from Scott Hart. Everybody looks at the Kaplan-Meier curves, but I think there's very interesting data on this part. They looked at, as I said, this is one group has CT plus the treadmill test, which is the blue bars, and the other group has treadmill only, which is the red or orange bar, depending on how your monitor is set up. And what you can see here is cancellations of medications on the left and new treatments on the right. Because if your test is appropriately informing, it's not only just finding more disease. It might just be that CT finds people that were being treated, but once you look at the CT, there's not disease or not enough disease to be treated. So what we see is from before the CT, so we had the medication before, and then after the treadmill or the CT, how much things changed. And from the treadmill testing, very little increase in terms of anti-ischemic medication, 11 cases after 2,000 on each arm, 6 cancellations. So a little bit of increase, a little bit of cancellation. Some patients were reorganized, redirected. And with CT, a lot more, both directions. A lot more people you're treating with anti-anginal because you think it's angina. A lot more people you stop the medication because you don't really think it's angina. Then if you go preventative, which is aspirin and statin, same thing. You cancel a few with the treadmill, but not much. You increase a few, but not that much. And with CT, you cancel quite a few. So 80 out of the 2,000, you stop it because you say maybe there's no plaque, and you increase medication in quite a few. So in total, you end up changing enough to say that with treadmill testing, you change 5% of the patients, the amount of medications, either preventative or anti-anginal. With the CT information, that goes to 23. So almost 1 in every 4 patients, there was a change in management, and almost 5 times more than the change that would come from a treadmill test. Kind of supporting the idea that we make therapeutic changes that we'll see have an impact based on the CT findings. And then I'll link the management part from a prognostic perspective on the level 5, because in the end, what matters is the patient outcome. So for a test to be really useful, it shouldn't only be feasible, able to make the diagnostic, inform the diagnosis well, and inform the management well. It should also, compared to not using the test, result in something different in terms of outcomes. And that's where I think things start to get really interesting. The red bars in this data are real life data. So this is a propensity, it was not propensity match, it was match, but I'm not sure if it was propensity, but it was a matching from basically all patients that in the Danish national system did treadmill, that stress testing or CT. So they got all the patients, I think it was 15,000 here, a couple of years of data, and they exclude people with prior disease. So this is no known prior disease, and this is all sort of outpatient, stable, chronic chest pain. And they looked at CT versus functional testing, irrespective of the results, just which test do you start with, what happens later. And what they show is you treat with more statins if you see plaque versus looking for ischemia. Use more aspirin if you look for plaque with CT versus doing ischemia testing. You may revascularize quite a bit more, so 70% increase in the volume of revascularizations with CT versus functional testing. And then this package of more medications and more revascularizations, don't know which is which, but the package led to 30%, so the 29% reduction in MI. So now we get to outcomes, 30% less MIs in this real life data from the Danish registry. And what I find very interesting in this data is that the blue bars here are from a meta-analysis that I did back in 2016, looking at PROMISE, Scott Hart, and other studies. And essentially, it's the same thing. From all the studies, we see an increase in revascularizations. We didn't have data for medications. Probably is the same. And 30% reductions in MI. It's not always that common that real-life data resembles trial data that well. So basically, this suggests that as well as in randomized trials, also real-life data supports the idea that if you start with the CT, you may treat with more of the preventative prognostic changing medications. You might revascularize more, and with whichever part of this difference in management it does reduce a significant, very important outcome, which is myocardial infarction, by about 30%. Okay, so going to the Scott Hart data originally, this is the famous graph from the second presentation of the data. 5 years out, it's interesting, curves continue to diverge a little bit, not as intensely as in the first 2 years, but still some divergence of the curve for outcomes. This is just death or non-fatal MI. But what I find interesting in their data, again, more than the main Kaplan-Meier curves are on the details. The top is invasive angiography, the bottom is revascularization. And CT starts as being more revascularization, being more angiography, as I presented here. But then this effects last for about 2 years. And by the end of 5, it's averaged out. So you're doing about the same. So we're not necessarily being more invasive angiography and more revascularizations with CT. We do that earlier on, but the other group will catch up. Because if we don't do it now, some people will need it later. So probably doing diagnosis and intervening on lesions earlier with CT. It's not a lot of people there. If you see in absolute terms, it's small, but there is a complete catch-up. And here you can see the catch-up really, really well. Year 1, there's maybe like a 2% increase in the amount of revascularizations in the CT arm. And then the years 1 to 5 have about a 2% increase in the other arm. So maybe this arm is elective. Maybe it's some of the MIs that then got a cath, but we did it early. They came up later, 4 years later. So ends up averaging out on the longer term. So even the increase in the invasive angiography and the revascularizations, if you get this perspective of longer term, may not be even that impressive. What is impressive is the difference in medication and persistence. The left is antiplatelet therapy at Scott Hart, the right is statins. And you see, we started close, the two groups, and then after year 1, one group is treated more than the others, and that difference persists for 5 years. Same thing for statin. And the blue bars, of course, are the CT arm. So seeing the plaque, convincing yourself what the plaque is, convincing the patient what the plaque is, and treating the patients as somebody that has plaque, and maybe even showing the images to the patient. I don't know if that was done, but the whole package of having the anatomical atherosclerotic information from the plaques rather than only in ischemic testing is something that has an effect on preventative medications that persist for at least 5 years with a meaningful difference. So that kind of explains the outcomes in Scott Hart to a big extent. But it's interesting because in this paper, it's a very interesting paper that they did, the sub-analysis in JACC. They have other data. They look by symptoms, which I don't want to focus that much on the symptom, but the prior CAD seems to behave different because they had prior CAD. It was not fresh, no known status for CAD. They had some prior on Scott Hart. And when you look by these characteristics, you can see most of the revascularizations are in the people you really thought the symptoms were real or had prior disease. And most of the prevention medicine, they have an effect in these two groups. So this is sort of a mix of the other two. But we can see the effects across time. And of course, this is an extrapolation of the data. But in these people, which probably are not as extensive disease than non-anginal and anginal, most of the benefit takes longer time and is seen after the first year, so up to 5 years. Whereas in the group that has more extensive disease, more plaque, as the prior non-CAD, a good chunk of the benefit comes early on. Some of the data here are small sample sizes, so it's limited, but it kind of suggests that maybe prevention in people you were not doing prevention in the first place has the longer term effect. But maybe revascularizations, if you believe the data and other data in revascularization actually conflicts that, but would suggest that if anything, the revascularizations, which are faster acting, might explain some of the early effects. Not sure if this is true or that robust, but at least give some hints on what effects come early, what effects come late, what kind of patients had some of the changes. And you can see different people got different kind of changes in their medication. If we continue on the outcomes data and we start moving to the other side of CT as initial test, which I'm going to talk a little bit more about, which is CT versus invasive angiography. So like changing the question from the usual, let's do CT versus a stress test, now is let's get everyone that goes to the cath lab. And instead of going to the cath lab, let's do a CT first. This is only atypical angina, so lower probability of obstructive disease. But these patients were going to invasive angiography in Europe, mostly Germany, if I'm not mistaken. And then the CT arm, of course, everybody gets a CT. And about 1 in 5 ends up in the cath lab anyway, because 20% have obstructive plaque that you feel like you should go to the lab. At least that's what you do in 2016. Of course, if you don't do that, everybody goes to the cath lab. So you can save about 80% of the patients with atypical angina or atypical chest pain that were going to the lab. 80% of them probably don't need an invasive angiography because you'll know what they have or what they don't have based on a CT test. And this has, of course, an improving diagnostic yield. Once you go to the cath lab, almost everyone has obstructive disease because the CT saw it first, versus if you don't, the vast majority don't have obstructive disease, and it gets sort of a waste of an invasive test. This has also been studied in randomized trials recently, so this is sort of older data. This is, again, data from Europe, published almost 2 years ago. And in this study, they again randomized people that were chronic stable angina going to, just 1 second, going to the cath lab. So initially they would go to the cath lab. Let's randomize half of them to go to CT and not the cath lab and see what happens. And basically what they showed, the CT has less events. And this is essentially driven by less complications. As if you go on the details of the table, all the events here are on the lower end, but this is essentially driven by a reduction on things like strokes, which is maybe a complication of the cath lab. Other studies have answered this, asked the same question before. So I'll just jump to a meta-analysis that, again, we did publish last year. And here you can see that versus starting directly to the cath lab, patients that were supposed to go to the cath lab, but you do a CT first, 80% of them don't need the invasive angiography because the prevalence of disease is much lower than we believe it is. And you end up with a profile that essentially reduces stroke, a trend in mortality that's not significant because the event rate is very, very low, no significant differences in MI or revascularization, and a trend to a little less revascularization. So if you do CT first, a lot of people don't need to go to the cath lab, but this doesn't translate in anything negative, but it might translate in a little less stroke and a little less revascularization. So overall, again, CT better outcome, at least from the complication side, with no downside of anything else if you choose not to do invasive angiography as the first test, even in people you thought that would be needed in the first place. So I think with that, we can say from a patient outcome efficacy or from a patient outcome perspective, CT is at least comparable to, if not better than, the initial approach with a stress test or with invasive angiography. So it's more extensive than what the guidelines say, at least the European guideline that keeps on the intermediate range. But even probably the very high probability patients, we have enough information to make that decision. And the last part for you to be a fully efficacious test from this framework is to prove this has societal efficacy. And that basically means, are you too expensive that you're not worth the benefit? Or from a society perspective, not an individual patient perspective, is it cost effective? So is the money worth the cost of CT overall? There's two, I think, interesting data from this. This is PROMISE data, a sub-analysis that was pre-specified as cost effectiveness. So basically show the costs are quite similar. And you see the confidence intervals here. It's very hard to say one test is less expensive than the other. It's not the test cost, it's the whole downstream consequences of the test. And this is mostly driven by how much revascularizations or CAT you do, because that's the expensive part. And you see, even after 3 years, there's maybe a 500 overall cost difference at best, but they didn't have precision with the 10,000 patients that promised to answer the question. So essentially, at least from this data, from actual real life US, mostly US use of the test, no difference. I think this kind of data is very sensitive to how you do things, because this is real life. So if you decide to be more aggressive on some findings or more conservative, that impacts a lot. So sometimes modeling with predefined parameters might be more interesting. This is kind of old data, but this is very interesting data, because even in 2015, within the context of some of the tests were not as good back then as they are right now, especially for CT. They did sort of a model for an intermediate risk patient, sort of a male in his 40s with chest pain. And they work with various scenarios on do one test, which is the empty symbols, do one test followed by invasive angiography with a certain framework, which is the colored ones. And then the crosses are start with CT, then add some sort of a stress test, or if it's both, then add a stress test to define better the use of invasive angiography. So just how many layers you put in. And essentially, no matter what, the less costly approach and the one with highest effectiveness, so better quality of life adjusted years, it's all the same. All the three bolded crosses here are start with the CT first to see if there's plaque and obstruction. Then if there is obstruction, follow that with some sort of a stress test. And only if that stress is positive, you should go to the cath lab. That's the less costly and the highest efficacy way of doing an approach for CAD. There's a difference in between the crosses, which is not large, and is essentially driven by the fact that stress AC was more specific than the other two that they modeled. At least that's the data they used. We can argue if that's true for CMR. But as I will talk later, if you start with a very sensitive test, which is the case of CT, it only makes sense to follow that test with something that has high specificity. The logic behind layered test is the first test, which is usually sort of a screening if you come from the real epidemiological data, but also our first test for CAD. If we start with something more broad, it should be more sensitive, not to miss people. But once you want to nail it down, the second layer test has to be more specific. Otherwise, you don't gain a lot of marginal information with the second test. But I think that data can allow me to basically conclude that CT has done the level 1, level 2, level 3, level 4, level 5, level 6 efficacy documentation that we would need for a test to be useful. And I'll just pause here for a second and allow you to think of the many other tests we use in medicine and in imaging. Which ones have done on a formal structured way all those steps and done it all in less than 20 years? There's not that many tests. We do a lot of tests, maybe for historical purposes, that have not been evaluated to this extent. This is not the end of my talk. I'll just move forward and say that's how we got to the guidelines. But I'm going to be a little bit beyond my initial title, and I want to talk about maybe CT could be the sole only test. And this is not for diagnosis anymore. I changed the title, but for the management of CAD. This is a little bit of a more provocative extension of the talk, but do we really need more data than the CT on our average patient with chest pain to manage these patients? CT is not a diagnostic test. As I showed you guys, it's a prognostic test. It has a lot more information, just obstructive or not, plaque characteristics. And this is PROMIS data, and this is the PROMIS definition of the moderately abnormal and severely abnormal test results. And you can read here the amount of plaque and obstruction in proximal disease of each one of the two. And here on the side, you have the prognostic curves of the CT findings versus the functional test finding. And we can find as high risk on the severely abnormal people from CT as we do from stress testing. So we can find within the people that have plaque, that have CT results, which ones are higher risk, which is the key to manage this patient. There is no data to support management based on ischemia. The management of CAD is based on the clinical risk profile, symptoms, and the overall risk, plus some other stuff that I will show you on the next slide. So now I'll go, and this is just based on cataracts, which you can essentially same idea, more obstructive disease with multiple vessels is where most of the risk is. But then we can go to the guidelines. This is what the guidelines say you should use to manage chronic coronary heart disease. Most of these things, it doesn't matter any of the findings of the test, like tobacco, alcohol. We do sort of a same thing for everybody. The ones that matter is the ones that I'm highlighting here. And I'm going to talk essentially about those just to show you guys that CT can guide pretty much everything we do, plus minus some additional information we might need. So let's go by drug then. And let's start with some drugs that are essentially dependent on ejection fraction or other clinical information. So SGLT2s that are on the guidelines, you treat them or not, once you have CAD, doesn't matter even your risk or your anatomy or ischemia. It's diabetes, heart failure, and ejection fraction that define it. Beta blockers, prior events, also questionable recently, arrhythmias, angina, hypertension, and ejection fractions. ACE, ARBs, and MRA, same thing plus CKD. So essentially, all those medications, maybe you need an echo for the F, but all other information to decide on the management are clinical. There's no additional invasive or non-invasive need for testing other than knowing there is CAD that could come from a CT. Lipid-lowering medication, statins is for all. Ezetimibe and PCSK9 by the guidelines are LDL plus risk, which CT can give you. As I showed you, the risk derived from a CT is comparable to a functional test. So you can guide those decisions essentially based on the clinical profile plus the CT information. Ezetimibe. This is a study subdividing the groups of risk in one of the ezetimibe studies. And you essentially see lower risk, not that much benefit, high risk, more benefit. But again, it's risk. It's a clinical risk, so you can say it's only clinical. It has sort of a prior revascularization in there, but essentially a clinical risk that maybe we can translate this level of risk from CT. But again, it's a clinical risk that defines it, not ischemia, not invasive information. And then if we go, aspirin is for everybody with CAD. TAPT is decided by MI, PCI, or CABG, or prior history of those things when they happen. And low-dose rivaroxaban from the COMPASS trial is high risk. We can't say whether the trial allows us to derive this from CT, but we can kind of compare the incidence risk that they got, which is not that far from what PROMIS got on the more extensive disease. So if you want to use rivaroxaban like COMPASS trial did, associated with aspirin, probably you can do that based on risk, and risk can be derived from clinical parameters and CT. Again, here's more data on rivaroxaban, but this pans out no matter what by how number of vascular beds, EGFR, heart failure, diabetes. Pretty much everything gets you to the same place, except for polyvascular disease. The more plaque and the more extensive and diffuse the plaque is, the better the effect of the added low-dose rivaroxaban. But again, the decision is essentially anatomical, a clinical risk, plus here some multivascular assessment of plaque, nothing else. And then if we go to colchicine, what the guidelines say is consider colchicine and secondary prevention. Then you don't even talk about risk. But again, no functional test, no invasive angiography. If anything, if you go to one of the trials, there is a criteria that is based on CT or invasive angiography or Agatston score. So if you believe the data of the study, there's a lot of questions about it. But if anything, that CT or your calcium score could be enough to inform how extensive the disease is, and does this patient kind of qualify for Lodoco criteria for colchicine? Again, risk and plaque is what you need. And last, I want to even extend that even more. Let's go to the revascularization guide. And you can revascularize a patient either because you want to reduce events, mortality, or because you want to reduce symptoms. If the question is symptoms, you don't need any tests. It's the patient's symptoms plus knowing it's CAD. So a CT and refractory angina, you know what to do. You don't need the functional test. So let's essentially talk about the indications to revascularize a patient from our guidelines for stable ischemic heart disease, how do we define? And we define by dysfunction. So again, EF matters, but then multivessel, left main, multivessel, proximal LAD, and multivessel. And there is a don't use here. This is a class 3, but it's not indication. So all the indications come from see the plaque, see the stenosis, count the number of vessels, say if they're proximal, say if they involve left main. This is all anatomical definition. That's what CT does. None of the indications to revascularize a patient from a prognostic perspective come from functional testing. You might say you need the invasive angiography to confirm the CT. So maybe as after the CT, you see that. But if the CT doesn't see this, why would you need to consider revascularization? You don't even need, if you look at this really well, same thing for FFR CT that we do a lot. The data here says essentially an anatomical information that guides revascularization. So I'll just say that maybe we can do everything with CT. But then you might tell me, and that's the last small part that I have, yeah, sometimes the CT, I'm not sure. There's the intermediate lesions, the lesions I'm not sure, the quality is not great. So you might need additional testing. And the last part I want to talk about is how do we decide on the next test? And this is the classical data of pre-test, post-test probability using likelihood ratios. So positives move you there, negatives moves you down. CT moves you a lot down. So once your CT is good, you don't need to worry about anything. This is working binary, so a little simplistic, could be a little bit better. So CT with extensive disease will be higher up than this, but this is just a binary yes, no. So CT can get you up here. So that's your initial test. That's where you get your initial test. But let's imagine a patient average like 20% risk. Once you get a CT with any over greater than 50% stenosis, you'll probably increase your risk by about 30%. And if it was probably multivessel, it would probably be even higher than that. But the thing is, once you are with a positive initial test, your follow-up test should be one that is able to bring you high up here. You don't care that much about this side. The negative part is not that helpful. You need to look for specificity to move up. And you see all the stress tests kind of do that, but the worst of them is FFRCT. So we kind of become as FFRCT should be the norm, but the data doesn't suggest that that's the best one to reclassify up. And if we don't do that, we just might end up with a test that I'm going to show you. It's not very specific. And if the prevalence is about like 20, 30%, as we said, and you have a test like 50% specific, which I'm going to show it's the case for FFRCT, you might end up with 70% false negatives, which is exactly what's been shown in the literature. So I'm going to show you guys that maybe FFRCT is not that great if you need to follow up with some tests. And here's the very interesting data that I think this is from the Pacific study. So it's FFRCT, coronary CT, SPECT, and PET. This is the table they present you, the top part. Very clear sensitivity specificity. And already know that FFRCT has lower specificity than anything else. This is each test ability. But when you go intention to diagnose, so you don't exclude X, Y, Z, your specificity is very, very low with FFRCT, about 50%. Positive predictive value of only 60%, even on this very high probability cohort. Whereas all the other functional tests are much higher. And what you care more after a highly sensitive test is a highly specific test. So it makes a lot more sense from an epidemiology perspective to consider the perfusion-based real stress test as a secondary test in the cases where the decision cannot be fully made based on anatomy. And that has been shown in this somewhat famous study from the UK that basically showed low predictive value of CT, and everybody got somewhat questioned the study and selective of the population, etc. But if you look back, it's not that different. It's not that different than the trial that compared all the studies from other groups. So it kind of makes sense that you start to see this low predictive value in the more questionable lesions because the FFR is derived from the same image. But it kind of supports the idea that most patients don't need functional testing, but when they do, maybe the CT-based information is not necessarily the next big step. So before I finish, I'll just say, I've shown you guys how CT has done a long way to prove it works. And it is essentially a diagnostic, prognostic, and management decision test for chronic CAD. And this all can be based on CT, plus minus clinical information, in most of the cases, EF assessment. And for selected cases, probably perfusion is what's left over, but that's only for a minority of cases. And invasive angiography, to me, with all the data we have, can be reserved only for those in whom we expect to revascularize. So essentially a treatment rather than a diagnostic tool, or a very selective diagnostic tool, as most patients should be doing CT as their initial test. And I'll stop here. Thank you very much.
Thank you very much, Marcio. That was an amazing lecture. I really enjoyed it and I learned a lot. For everyone, please put your questions in the Q&A and we'll start going through them. I'll start with one related to what you talked about perfusion. What do you think about CT perfusion? I mean, it's something that has been hanging out for a while, but with the newer scanners, you think, is it ready for prime time?
So I've done research with CT perfusion and I interact a lot with many people that have done many of the main papers in CT perfusion. I think it works. It's not as good as probably PET or MRI, but it's not as bad as some people make it sound. If you know how to do it, it works out well. There's some caveats into using that in terms of workflow, because unless you believe everybody needs a stress perfusion for CT, usually start with the rest. So the way people mostly would do it is start with the rest and get the angio. But then either you book double slots and don't use the other slots, or you have to find some way of fitting the patient in, which is problem number one. Second, if you want to do it at the same time, somebody has to pre-read the coronaries, believe there is enough disease, and then move forward with the perfusion, which makes it kind of clumsy because most people are not reading on the scanner right after. If you take an hour to read, do you hold the patient? Do you hold slots? So from a logistic perspective, it's not as easy to implement. I think the data supports its use, but it's not as easy to implement. And then if it is to bring the patient back next week or next month, then it's the same hassle or work as doing any other perfusion test. And then there's data to support that probably PET and MRI are a little bit better. It's pretty comparable to SPECT, but we're not gaining much by bringing somebody back to CT. And I don't think creating a workflow where it's easy to make sense of it is that simple. If you have a schedule that's not super busy on your scanner and you can just hold the patient for an hour, read the study and bring them back in, it might work. But in between the billing part, the logistic part, and how we usually do the workflow, I think ends up not being something I'll see moving forward. And it's not because it's not technically feasible. It's moving to the technical feasibility, to implementation phase that gets it stuck. That is my impression.
Thank you very much. Yeah, I agree. Maybe some of these automated pre-reading softwares could help us at some point to
maybe if you go something that way, it would work, but it has to be something quick. Otherwise, the workflow just crashes very easily.
Okay, so let's go through the questions. We have from Tarun Mittal. Dr. Bittencourt, he mentions that the ESC guidelines that you initially showed are the previous one, and he mentions in the change in the 2024 guidelines that recommends CTCA as a first-line investigation for low to intermediate pretest probability with level 1A evidence. Any comments?
Yeah, that figure is truly from the 2021 or the 2024. It's not a big difference, but kind of it's correct that workflow is from the prior one. I think I didn't update that one.
Is it worth saying low to intermediate, or should we use it in high? I mean, all the data shows a high too, right? I mean,
so I think there's some problems in that discussion. That boils down to the bigger picture discussion that has been hanging around and not sorted out as of yet, which is defining what CAD is to start with. Because if you want to talk the probability or a disease, you have to know what disease is. And the disease that we talk about used to be called ischemic heart disease, and then it became coronary artery disease. And now it's becoming something coronary not obstructive. Before, early on, the clinical CAD was defined as obstruction or ischemia or prior events. And now we're going to the non-obstructive. So first, we have to decide what do we want to call disease to then talk about all that. And my understanding is this is a spectrum that mostly stays on the asymptomatic individuals with some plaque and goes all the way to the ACS events. And then rather than saying this test is able to say, yes, no, there is disease, is a test that tells you how much disease and risk there is. And when there are symptoms, how much does the test result of the extent of disease explain the symptom? And that becomes meshy. It's probably no longer a sensitivity specificity binary question. It's a little bit more, say, shades of gray, not to say something else. So it's a complicated thing that it's not as much on the CT or any testing end, but it's on us defining what we're looking for with each test. If you want to look for plaque for risk assessment, CT is the only one in non-invasive modality to do it. If you're looking to explain symptoms, probably the functional test is comparable to CT. If you're looking for prognostic information, then they seem to be somewhat comparable for the presence of ischemia or the higher risk, but on the lower end, seeing plaque is better. So probably you need plaque to start with, and then you can add the functional or add the obstructive from the CT as an add-on information. But I think it's very hard to explain it all because we don't know what the name of the disease and the definition of the disease that clearly. That's my understanding of the problem.
Thank you very much.
We will change that. I see us coming with a new, because what the guidelines did in 2021 is just include all the non-obstructive into the pile as all CAD. And I think that's not that good because then you're going to talk everyone at 10 calcium score CAD as clinical to the same way you do for a posterior vascularization. Also not that informative. So it's much better to have multiple bins or levels or categories rather than try to define disease too broadly.
New things come in that way, some that we're doing here. But from Robert Osfeld, thank you for a great talk. In Scott Hart, did they assess whether the patient visualizing their plaque impacted the patient's adherence to lifestyle change? How effective is it for a patient visualizing their plaque to achieve some degree long-term over 1 year, helpful lifestyle change by the patient?
I don't know if they did on Scott Hart. I don't know that part of it. I know other studies have done, and some smaller studies suggest that showing to the patient what diseases increase adherence. They're all small studies in shorter term than the 5 years data. But from Scott Hart, I'm not sure exactly how the CT information was translated to the patient.
I believe it was up to the physicians, right? But it was not like the Eisner trial that was structured to show it.
I don't think there was anything structured, but I don't even know if the image was readily available that the ones that wanted to share could exactly share. I don't know how they did that.
Thank you very much. A question from Daniel Lorenzati, superb lecture. I am 100% in agreement with that. Invasive angiography could be wrong versus CCTA. If you see the prospect trial, most of the lesions considered non-obstructive by invasive angiography had high plaque burden and low minimal luminal area by IBUS or OCT. Also, how many cath labs do QCA or intracoronary imaging instead of eyeballing stenosis? Yep. Question is, what do you think of using CT-derived minimal luminal area for stenosis grading?
I personally don't like the objective measurements from CT. I think there is some built-in imprecision by our pixel size and the quality of our data. Maybe the photon counting high quality ones, that works a little bit better, but it's somewhat labor intensive in between correcting things, or if you're paying somebody to do that with any semi-automated vendor doing that, which I'm not sure it adds, at least to where we are right now, that much information. If we start doing CT to plan procedures and focally define things for procedures and a higher extent of disease patients, there might be some additional information, but the usual clinical read for somebody with chest pain or higher like clinical profile where we want to overall quantify the plaque extent and disease, I think the classifications of obstructive and number of vessels, which usually is the information that guide revascularizations and clinical management, are usually enough. And I'm not sure we are as good as to say this is 1.2 versus 1.5 minimal luminal area as of right now. But maybe with a good scanner and good quality we can, but more broadly, I'm not sure we're there yet.
What about the patients with stents? Do you think we're there yet or
stents?
Not?
I think stents are it's a bit of a hit and miss, in my opinion. I have done a lot of stent stuff many years. And of course, it depends on your scanner. Newer, better scanners are better for stents, but some stents just look nicer than the others. And it's sometimes also the orientation of the stent versus the X-ray coming in. Some stents are sort of the same, and in one vessel, they look much better than, or in one patient in one vessel, better than the others. So, I mean, the bigger, it's easier. Some of the ones, there's some models that we know are a little bit better, but in general, it's a hit and miss. Some of them look great, some of them not so good. Of course, the newer Canon scanner that has higher spatial resolution or the newer Siemens are better because they reduce the blooming artifact. But I still think some of them look great. Most of them are okay. And some of them are completely unreadable, especially the small distal overlapping, etc. But my take on stents is if there's a big clinical question when there is a stent, it's probably fine for us to do it. If it's the clinical question is solely knowing the stents inside the stent, in-stent restenosis question, and it's a distal or multi-vessel thing, then risk is we might not be able to answer that question. That's my take. I don't think we're completely there for stents for sure with any scanner.
Thank you very much. I like that point because when you look at the meta-analysis and all the data suggests better than what we see in clinical practice. There's a lot more variability when you're actually doing it.
Yeah, when you start not filtering, like allow people to send in, and you get all stents, the torture stents that people had to put another stent inside, or overlap, or bifurcations, or extensive calcification of the stent inside the calcification. It goes layers of becoming more tricky than when you select cases. If it's a single mid RCA, low heart rate, 3 mm stent, it's probably going to be fine. If you're talking about a tortuous OM branch, it's a stent that you're not even sure there's a stent that small, probably not going to work. So I think it depends.
Thank you very much. Last question from Tarun Mittal again. He says, in my practice, around 14% of patients undergoing CTA as first-line investigation are found to have severe CAD and undergo revasc. However, only 4% of patients having stress testing are found to have severe CAD and requiring revasc. What is the comparison with other centers? Do you think this is a universal percentage? Probably not.
I think that the amount of disease you see depends on the profile of the patients your clinicians order to you. I'll tell you, I've worked in multiple places. One of the places I worked in Brazil, we did a lot of lower risk. I wouldn't even have 3% obstructive disease in that one specific place, because we're scanning mostly low risk patients. Here, what we do at Presby is a little higher risk, higher probability. I see a lot. I don't know exactly the numbers. I haven't tabulated, but it's much higher. So I think it starts from what the kind of population you're scanning. So absolute numbers, I think it's highly variable depending on the CT used in your center. But if you're talking about the proportion, I'm not surprised that you're getting twice more obstructive disease from CT versus perfusion on whichever perfusion or stress test you're using. I do a lot of CTs for like symptomatic patients with normal stress tests, and some of them come normal too, but some of them come very extensive disease that they didn't see. So I think there's a lot of mismatch and differences in what is found, and I think CT finds a lot of significant, severe multivessel obstructive disease that sometimes is normal or something confounded with an artifact in some of the, at least the nuclear studies.
One last question to keep everyone happy. They ask us, this question comes from Victor Becerra Gonzalez from YouTube. He asked if you could comment a little bit more on the age. So elderly patients,
As I mentioned in the beginning, I don't have major concerns with elderly patients. Not all of them have very high calcium. Not all of them are hard to scan. Most of them, I mean, if it's an elderly patient that you know has a lot of calcium and cannot get beta blockers, it's a different picture. But I wouldn't go by any age cutoff. But I would say, like, once you get to your 80s, 85, chances of more calcium are higher, and maybe you end up with some segments non-diagnostic. But I usually don't do age cutoff, as I usually don't do calcium score cutoffs. I mostly try to scan everybody because I think that there's meaningful information. Even if sometimes I say one segment's non-evaluable, the rest of the anatomy might be enough to inform management. So I tend to not be very restrictive on that. But depending on how the clinician feels about the result, it could be different. But at least into 75 to 80, I don't see major problems purely coming from age.
And probably if you're in your 80s and you don't have left main or proximal LAD, you shouldn't be doing stents on distal vessels because the rest. If
the symptoms are not refractory, that's what I say. If I can tell you a lot of calcium, you know prevention, how to manage the patient. If you know there's nothing too severe proximal, you can do medical management if you think the chest pain is coming from the plaques I'm seeing, and you can try on that. So it might be informative to know how much plaque and know that some segments are normal, even if I can't read some of the distal segments. That's my take on preferring to scan most patients, even though I might say PDA is non-assessed, cannot be assessed, or I'm losing one OM or something like that. Of course, there is a risk I will not see the proximal LAD in a few cases, but that's part of the method. Sometimes you get non-diagnostic studies for real. But I think the distal ones and some of those patients, they just don't matter that much. You'll know how to manage the patient regardless.
Awesome. Well, thank you very much. It was a real pleasure, and hope you have a great weekend and come visit us in New York.
Thank you. It was a pleasure. I hope everybody enjoyed, and good weekend for everyone. Bye-bye.
Bye-bye.